Hello all, let us continue with our session on escalation and de-escalation of antibiotic regimens. It is to be noted that only MIC-based and sensitivity testing is recommended for antibiotic susceptibility testing. This difference is not a reliable method, particularly for antibiotics like colistin, fosfomycin, aztreonam, wherein this diffusion provides a false positive results. There are particular group of antibiotics for which only MIC-based AST is recommended. Do we need MICs to treat? Yes. For multi-drug resistance or XDR or carbapenem resistance gram negatives, MS is needed to evaluate high-dose carbapenems versus tigecycline versus colistin as the backbone of the combination. Then in MRSA to decide whether to use daptomycin. Let us understand the importance of MRSA to some examples. If the infection is bloodstream, the empirical treatment core drugs are high-dose meropenem or doripenem or polymyxin B. The empirical treatment possible adjunct drugs are aminoglycoside, tigecycline, fosfomycin, rifampicin. And the directed treatment considerations are meropenem or doripenem. Then the MSC should be less than or equal to 16 microgram per ml. Continue high dose meropenem or doripenem as needed. If the MSC is more than 16, then consider alternative in vitro active antimicrobial. For lung, if lung is the source of infection, then high dose meropenem or doripenem will be the core drugs for empirical therapy. Adjunct drugs will be tigecycline, aminoglycoside, fosfomycin, rifampicin. Now, what will be the antimicrobial susceptibility directed treatment consideration? Polymyxin B or colistin. Then, if the MIC is less than or equal to 2 units, then consider polymyxin B or colistin. If the MIC is more than 2, then consider alternative in vitro active antimicrobial. If the source of infection is GI tract, then empirical therapy will include high-dose meropenem or doripenem and polymyxin B and high-dose tigecycline. The adjunct drugs will be fosfomycin or rifampicin. If both meropenem or doripenem MIC is more than 16 and polymyxin or colistin MIC is more than 2, then consider a high-dose tigecycline based regimen or a dual carbapenem based regimen. If the source of infection is urine, then empirical therapy should be considered as high-dose meropenem or doripenem and fosfomycin or aminoglycoside. Adjunct will be colistin or aminoglycoside. The consideration include if pan-drug resistant infection, then select case reports support dual carbapenem based regimen. Tigecycline MIC is less than 1, then consider tigecycline. If the MIC is more than 1, then consider alternative. Fosfomycin MIC less than 32, consider fosfomycin. If more than 32, consider alternative. Aminoglycosides MIC less than 2, then gentamicin or tambramycin, or less than 4 for amikacin, then consider aminoglycoside. If MIC is more than 2 or more than 4 accordingly, then consider alternative. For vancomycin sensitive Staph aureus, if the MIC is 2, then beta-lactam is always preferred if methicillin susceptible, vancomycin susceptible Staph aureus is present. Perform MIC if invasive infection is susceptible. Vancomycin susceptible Staph aureus with elevated vancomycin MIC. Then note variable method and value for elevated MIC. MIC less than 2, optimize vancomycin dosing modified by according to the MIC to AUC ratio. Potential vancomycin treatment failure and increased mortality, then optimize the vancomycin dosing. Source control, consider alternative antibiotic if clinical failure occurs. Perform MIC if invasive infection is present. MIC result differs according to method. If there is a heterogeneous vancomycin intermediate Staph aureus and MIC is less than 2 plus modified MIC to AUC is more than 9, then screening for the GRDE test. Potential vancomycin treatment failure, optimize the vancomycin dosage source control, consider alternative antibiotic if clinical failure occurs. Perform MIC if invasive infection is present. Prioritize heterogeneous vancomycin intermediate Staph aureus screening if risk factors are present. Vancomycin intermediate Staph aureus, MIC 4 to 8, then avoid the glycopeptides, have a source control. Facility susceptibility testing for alternative antibiotics. If it is vancomycin resistance, that is MIC more than 16, then avoid the glycopeptides. Confirmatory testing needs to be done for resistance mechanism, that is wine gene testing. Let us understand the concept of MICs and breakpoints and the importance of using the breakpoints. If you see the categories of these antibiotics, wherein we have the sensitive, we had a categories of resistant, intermediate, sensitive, and for this different groups of antibiotics. So based on the clinician should not rely on these categories of susceptibility reported. The MICs and the breakpoints needs to be considered. Now, if you see the MICs, if in order of MICs, drug D is more sensitive than C, then E, then followed by B, E, and A based on MIC. However, if you consider the breakpoint to MIC ratio, then the favored drug will be drug C followed by E, then D, B, and A. That to explain here, drug C, more the breakpoint to MIC ratio, the more the effective than the antibiotic. It should be at least 2 or more than 2, the ratio of susceptibility breakpoint to MIC. Now here in this amongst these five antibiotics, drug C has the highest breakpoint to MIC ratio, that is 16, followed by drug E, that is 4, then followed by drug D, that is 2, then followed by B and A, that is for half and 0.15. So the expected efficacy in order of breakpoint to MIC quotient will be C, then E, then D, and B and A. However, in activity of MIC, it was completely different. That is D, C, B, and A. So MIC alone should not be relied for selection of the antibiotics. It is the breakpoint to MIC quotient that is important. If it is a multi-susceptible organism, then ampicillin sulbactam will be the choice, or ceftriaxone. ESBL, where in a broad dilution method testing is done for antibiotics, then an MIC of peptide less than 8, then consider peptides. If it is done by broad dilution method and the MIC of peptide is more than 8, then consider meropenem or carbapenem sparing is considered. Then have ceftazidime or tazobactam or ceftazidime or avibactam. If it is MC producer, then meropenem, or if you have to spare the carbapenem, then cefepime will be the choice. EPC, then ceftazidime avibactam or meropenem vaborbactam or imipenem varilibactam or cefiderol. 48, then the drug of choice will be ceftazidime avibactam or cefiderol. MBL producer, and if it is NDM producing, then ceftazidime avibactam plus aztreonam will be drug of choice, or fosfomycin plus meropenem. If it is VIM or IMP producing organism, then fosfomycin plus meropenem or cefiderol. So that's all in this session of escalation protocols of antibiotic regimen. Thank you.